I'm Dr. Bob Wright, and I'd like to talk with you today about patient behavior from an applied behavior analytic perspective. Poor adherence to medical treatment is widespread and well recognized, as are its consequences of poor health outcomes and increased healthcare costs. In the outpatient setting, there are four commonly reported approaches for measuring medication adherence: self-reporting, electronic monitoring, pill counting, and pharmacy fill rates. With 929 million patient visits a year, if 1% had a bad experience, that's more than 9.2 million dissatisfied customers. The B-MAAS is one of the tools we developed in our adherence management coaching toolkit that I'll talk about today. When every other patient we see has the potential for non-adherence and the impact that MACRA and MIPS will have on future earnings, we need to take a more scientific look at patient behavior and what we can do to both increase adherence and reduce exposure to critics claiming that providers are not offering quality care. If the only party in this effort to improve outcomes is the provider, then 50% of the relationship is being given a free pass in terms of being held accountable. The discharge plan or plan of care is the blueprint for achieving the best clinical outcome. John's plan, shown here, shows the need to start or continue 8 medications. 12% of all prescriptions are never filled. A proper clinical workup, diagnosis, patient education, and plan of care is not representative of poor quality care if the patient chooses to disregard the plan. There's more to the problem than not filling prescriptions. Another 12.5% have their prescriptions filled, and they either don't pick them up from the pharmacy, or they do pick them up and then choose not to take their medication once they get home. 29% start taking their medication, and then, because they're feeling better, or the medication is making them feel worse, or the cost, or any number of reasons, they stop. The end result in each of these three categories is an eventual patient experience that is not satisfactory. As provider rating programs increase and reimbursement is based on patient satisfaction, there will be a significant impact on both providers and patients. The World Health Organization reported 5 primary factors contributing to non-adherence. They also reported that at least 69% of adherence is the result of behavior. As a behaviorist, we look to actual behavior. We see this list in terms of antecedents, or things that lead to behavior, the behavior itself, or the things our patients do and the consequences. These are things that happened to our patients that increase or decrease the target behaviors. The highlighted words tend to be found in most research programs as common themes for non-adherence. In developing our medication adherence assessment scale, we included the data from the World Health Organization. Our goal was to develop a scale that was easy to use and provided a graded risk scale to indicate which patients were most at risk for non-adherence. Our applied behavior analytic approach understands that behaviors have an antecedent, or something that cues the behavior, and all behaviors have consequences. Our global behavior is following the plan of care. To validate our antecedents, we match them to known consequences related to adherence. We looked at the research completed by Vermeer and others that supported the World Health Organization findings. Vermeer did a 10-year meta-analysis of known indicators for clinical non-adherence and reported them in the Journal of Clinical Pharmacy and Therapeutics. We divided their data into 4 sections: demographic, disabilities, or other contributing factors, and habits. And we use green, yellow, orange, and red to identify risk levels. We believe the patients at greatest risk are those who fall in the higher yellow numbers through the orange. As a rule, patients who fall in the red scale may likely reside in nursing homes or be under the watchful eye of family members. That doesn't mean we should ignore them. It's just that someone else may be paying attention to their medication schedules. Age is also inversely related to risk. The younger populations may believe they can overcome their medical problem, or it's not as bad as their provider says. The net result is an increased risk. Vision and hearing impairment increase the opportunity for mistakes and misunderstanding. Each of the areas represent a subjective evaluation by the provider and should be determined when speaking with the patient. Some of the questions are very specific, such as questions 19 through 22. The net result is a screening tool to indicate to providers which patients present as a greater risk for non-adherence. The majority of factors are antecedents or events that lead to behavior. The interesting component of antecedents is that while they may lead to behavior, they're not terribly reliable. Stop signs, for example, are antecedents, but generally only affect car drivers. Passengers can ignore the sign of the stop signs without any consequences whatsoever. What is reliable are consequences? Consequences either reinforce or punish the behaviors that occur before that consequence actually occurs. The easiest distribution of consequences are four pairs of outcomes: positive and negative, immediate and future, certain and uncertain, aware and not aware. The consequence analysis will be discussed in a later webinar in which we get into the specifics of the difference between positive and negative, immediate and future, etc., and how they have an impact on patient behavior. A study conducted by the American Society of Consultant Pharmacists strongly supported that a number of factors lead to non-adherence, as shown on this slide. This information can be closely aligned with the results of studies done by Foster and Sullivan and AstraZeneca. They divided these events into what they referred to as behaviors. A closer look will show that only choice is the behavior on this slide. Once again, we look at these terms in relation to what a person says or does, and have divided the terms into consequences and antecedents. While the estimate is that 69% of the factors leading to non-adherence are behavioral in nature, only one of the 8 factors is in fact a behavior. That is 12.5% of all the factors. The other factors are either antecedents or consequences. Patient choice is affected by convenience, expense, and distrust. Others may accept their illness as the will of God or fate and let nature take its course. Once again, this is a choice, and an accepting attitude is an antecedent. Illness is an antecedent rather than a behavior. Without illness, there'd be no need for a plan of care and no chance for non-adherence. All we need to know about identifying patients at risk for non-adherence can be found on this slide. All behavior begins with a need or cue. Whether the behavior continues or not is determined by the consequences. Choice is a behavior. Motivational interventionists state that patients are ambivalent or have wrong thinking. To a certain degree, they're correct, but the ambivalence is based on the consequences related to their plan of care. All choice is determined by antecedents and consequences. Choices are made every day based simply on the inconvenience built into the plan of care. By tying the antecedents to consequences, we can see that this particular medication plan, while clinically appropriate, places a significant burden on this 38-year-old male patient to manage his life around his medication schedule. The B-MAAS is an effective tool that will get you closer to understanding which of your patients are at risk for non-adherence. In the final analysis, being able to identify the at-risk patient and then looking into how they manage their care is significantly better than having them readmitted after a week or two of not following your plan of care. This patient in the example was diagnosed with chronic right-sided congestive heart failure, pulmonary hypertension, and COPD. Not only is the time schedule inconvenient, looking at the cost of his medications, we see another punisher. Consequences are either reinforcing and support our new habit, or they can be something we want to avoid. Without insurance or other medication subsidies, it's easy to see that a monthly medication bill forces patients to make a choice between paying bills and purchasing medications. Illness and the perception of illness are antecedents to following the plan of care. As you will learn in this course, in a later course that we have in consequence analysis, the lack of symptoms contributes to non-adherence. Medications used to treat a number of diseases are quite effective. Once again, the absence of the awareness that their medications are actually working often lead to non-adherence. Forgetfulness in the absence of organic disease is the get-out-of-jail-free card for most patients. Not doing something is not a behavior. Remember, behavior is what we do. In the case of patients who truly are unable to retain information, forgetfulness is an antecedent. Forgetful tends to be a convenient and relatively acceptable answer for most providers. Unfortunately, it does not overcome the non-adherence. Forgetfulness requires a closer look with the consequence analysis. When the consequences are peeled back, the forgetfulness will be tied to convenience, cost, side effects, or distrust. If you don't know the cause of forgetfulness, You'll constantly be chasing a moving target. Side effects represent a negative, immediate, uncertain consequence that our patients are able to feel. In most television ads, there's a brief discussion of the advantages of taking this medication or that medication, and these are always followed by a longer discussion of the side effects. This increases patients' concerns and can focus a patient's beliefs that taking medications can be very dangerous. Failure to accept illness is associated with poor quality of life in patients with chronic heart failure and other chronic diseases, according to research published in the European Journal of Cardiovascular Nursing. Patients with lower illness acceptance more often had lower energy levels, more severe pain, negative emotional reactions, sleep disorders, and limited mobility. They were also socially isolated. Acceptance is also a fundamental tenet of every major spiritual and religious tradition. In Christianity, acceptance is expressed as putting your faith in God or Jesus. In Islam, the phrase inshallah means as God wills. But whether you're religious, agnostic, or an atheist, I believe that cultivating acceptance is absolutely essential for anyone living with chronic illness or pain. It can also mean accepting and shaping your patient's behavior to be supportive of their plan of care. Physicians play an integral role in medication adherence. Patients who trust their physicians have better two-way communication. Trust and communication are two elements critical in optimizing adherence. Numerous studies show that physician trust is more important than treatment satisfaction in predicting adherence to prescribed therapy and overall satisfaction with care. Physician trust correlates positively with acceptance of new medications, intention to follow physician instructions, perceived effectiveness of care, and improvements in self-reported health status. A recent meta-analysis of physician communication and patient adherence to treatment found that there's a 19% higher risk of non-adherence among patients whose physician communicates poorly than among patients whose physicians communicate well. Statistically, the odds of patient adherence are 2.26 times higher if a physician communicates well. This translates into more than 183 million medical visits that need not take place if strong interpersonal physician-patient communication occurs. Communication contributes to a patient's understanding of illness and the risks and the benefits of treatment. Hence, the medical challenge is to improve communications between physicians and their patients. The key to making sense of all the lines on this chart is a patient-centered review of the plan of care from the patient's perspective to find out where the punishing aspects are. Patient satisfaction ratings are being used to judge physicians' quality of care to determine physician reimbursement starting in January of 2017. Many providers will spend an hour a year in front of their patients. That's 1 hour out of 8,760 hours in a year. In that hour, you'll provide a diagnosis and perhaps a very complex plan of care. Your patients may sleep just under 3,000 hours in that year. That leaves more than 5,000 hours of talking with friends and family about their care. Your 1 hour out of 8,760. How much of an impact can you make in that hour? And how will you reinforce the behavior changes you want your patients to make? How impactful can 1 hour have on the patient's experience? To have an impact on your patient's experience, you have to know which patients are most at risk for not following your plan of care, and then work with them to improve adherence. We call that adherence management or ADAM coaching. ADAM coaches identify at-risk behaviors and measure their baselines. They can establish an adherence improvement plan and work with family members to reinforce target behaviors. Equally important is celebrating the successes as your patients achieve them. Patient adherence, when it gets down to the bottom line, is about choice. Non-adherence is such an overwhelming worldwide problem that it will never be completely resolved, but that doesn't mean that you can't make a significant dent in improving patient outcomes in your practice. The Medication Adherence Assessment Scale is a relatively simple and practical tool for use in clinical settings. The instrument can be used initially to identify patients with adherence problems and can also be used to monitor adherence over the course of the treatment. One important feature of the scale is that treatment-related attitude and behavior problems that the patient may be facing can be immediately identified, and the healthcare provider can provide reinforcement and advice as such that the patient can take positive steps early on to address their own issues. Learning new habits and replacing old ones takes a concerted and targeted effort. Patient education is a nice thought, but education is an antecedent to behavior. Unless there are reinforcers and a plan to sustain the new habit, all behaviors will return to baseline. In following webinars, I'll go into detail about each of the steps that we take and how they can help you with your patient's experience. Experience is about behavior. Improving clinical processes, improving policies and procedures are also important. However, these are antecedents as well and will not create long-term behavior change. If you want better patient behavior, reinforce the behavior you want. You will see a change. For more information, contact Bears at 321-439-5949. We can show you how. Thanks for taking time with us today. We look forward to being with you again as we move forward with the patient experience.